Sir?
Yes.
Yes, it has started live streaming.
Shall I go back?
Sir, if you can go back and just recap fast, it will
Yeah.
be very
I'll
great.
recap fast and I'll go back and recap fast.
Yes,
Okay.
sir. Yes, sir. There was some problem and it did not go live. Luckily, I checked.
Thank you.
Are you able to see
We just
on that page? Are you able to see
we just
on that page? Are you able to see
we just
on that page? Are you able to see
we just
on that page? Are you
hello.
able to see?
We just hello. 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 Asha.
Yes, sir.
Now we
Proceed.
can hear you.
Proceed. Proceed.
Asha?
Yes, sir.
Yes,
Proceed.
yes. There are
Yes, sir.
some
Proceed.
Now we can
echo
hear
which
you.
is
Proceed. Proceed.
Asha?
Yes, sir.
Yes,
Proceed.
right. Yes. There are
Yes,
some
sir. We can hear you.
say there are some resounding Asha.
Now we can hear you.
There are some right. See, pelvic organ prolapse, an entity well known since time immemorial. And even though there is negligible mortality in prolapse and following surgery, but there is a significant morbidity is associated with it. Basically, pelvic organ prolapse is seen in the elderly, but it has got a distinct entity in nulliparous women also during reproductive period, which is very, very significant. See, out of many things, one I would like to say the iatrogenic or the post-surgical prolapse, which is basically because of an ill-chosen and ill-done operation. Pathogenesis is ill understood even now. It is because of the understanding of the pelvic anatomy is still surrounded by myth. You see, we always say that uterus is suspended with some ligaments, basically lateral broad ligament above, and the main ligament are the uterosacral ligament and Mackender's ligament or the transverse cervical ligament. The peritoneal pouches which unfolds anteriorly and the posteriorly, and the ligaments which hold it with the bladder, with the rectum in the front and the back are the important supports, along with the main muscle of the levator ani, which keeps the uterus in the proper position. Because of anything which go wrong with them, there can occur a prolapse. So it is the suspension in the upper, attachment in the middle, and the fusion in the lower is the rational concept of the pelvic organ prolapse. So classification and studying is still an enigma and controversy. Why I say? Because some classification is easy to understand, easy to practice. The other one is more theoretical, more methodical, but difficult to practice. The issues which is really associated with it is what does pelvic organ prolapse means? It means that the descent of the uterus via naturalis or through introitus along with the anterior and posterior structure, meaning the bladder and urethra in the front and the rectum and the intestine in the back or posteriorly along with the descent is constituting pelvic organ prolapse. There are many factors which are responsible: poor ligamentary support or weakness, debility, malnutrition, repeated childbirth, and so on and so forth. There are certain aggravating constipation, repeated cough, increased abdominal pressure, all that you know. I have already told about the supports of the pelvic organ. So the classification system are many and we still want to have a consensus on this. If we adopt certain preventive steps, then only pelvic organ prolapse can be prevented. And the surgery there to also need some preventive steps. A rational treatment, the conservative management will be told by Dr. Samir Pradhan. I am waiting to hear from him. And there is a lot of controversy and consensus on this. So the factor responsible, the activating factor, the inherent weakness in the support of the uterus, pregnancy and repeated childbirth, menopause and post-menopause. Because of the estrogen depletion, there is laxness or slackness or supports and the uterus falls down, and iatrogenic post-surgical I have already told. The aggravating factor are chronic cough, raised intra-abdominal pressure, debility and asthenia are constituting this. The pelvic organ has supports. The three supports are ligamentary support, fascial support and muscle support. These are all you know. The fourth dimension, the fourth one is the biochemical support or the hormone or the estrogen is that. The ligament we know, the transverse cervical ligament or Mackender's ligament, uterosacral ligament in the back, broad ligament in the upper, and the fascia which surrounds it, the muscle I have already told you. So the supports or the level of support, Delancey has made a three-tier support system. The upper part is the suspension, the middle part is the attachment. You see, the uterus is suspended by the folding or unfolding of the peritoneum, the utrovesical peritoneum anteriorly and called posterior one is the pouch of Douglas in the back. The peritoneal support is suspends it, and middle is the attachment of the ligaments, and lower is the fusion which I told you. The classification, so the older classification I will like to say that it is based on the anatomical sites. At what site, at what position the uterus remains. It is the descent of the uterus which was the main factor of deciding the classification system. So, when you stage it, we say mild, moderate or severe. This is vague, this is arbitrary, but we cannot quantify it. The strength is, it is easy to define. It is easy to define, but and easy to practice also, but you cannot quantify it. The weakness is that it is subjective, intrapersonal variation, and because the one which I would like to say that we have got two types of classification. One is a SAW classification, one is a Malpass classification. You say stage 1, stage 2, stage 3 or stage 4, or what you say first degree, second degree, third degree and fourth degree. It is told that if the uterus has come down from its normal position, and the landmark here is the ischial spine. And you see, the level of the ischial spine and the position is determined in relation to ischial spine. So if it has come down from its normal position, but still remains in the introitus, it is called first degree. Second one, if it is comes out of it is called the second degree, and the uterus has come out entirely of the introitus, it is called the third degree, and fourth one we call as procedencia, when you are able to reach above the fundus of the uterus. The entire thing has come out. Uterus, again, second thing is that uterus cannot come, unlike congenital or nulliparous prolapse, only there will be descent of the uterus, but normally in the postmenopausal or elderly women, the uterus will come down along with the anterior structure and posterior structure. So the weakness here will be subjective and there will be interpersonal variation. To me, it can be a stage 1, to somebody it can be stage second degree, and we do not discuss about the anatomical defect, and it also lacks quantification. So second thing is that we have a traditional anatomical site of prolapse classification. I told you the structure anteriorly is the urethra and the bladder. Upper one third is the urethra. So prolapse of the lower anterior vaginal wall involving the urethra only. Normally urethrosil, so moto or only does not occur. Second is cystosil, which is prolapse of the upper anterior vaginal wall involving the bladder. Generally, the prolapse of the urethra is also associated along with cystosil. So it is called cystourethrosil, right? And Hence, the term cystourethrosil is often used and coined. So, uterovaginal prolapse, it is the middle one, remains the uterus. So, the term is used to describe the prolapse of the uterus along with the cervix and upper vagina. Three things at a time. That is why it is called uterovaginal prolapse, not uterine prolapse. Second is the posterior one, enterosil, prolapse of the upper posterior wall of the vagina, usually contains small bowel, so it is called enterosil. Prolapse of the lower posterior wall of the vagina involving the rectum, which is bulging forward into the vagina, is called rectosil. So the anatomical classification, if we divide the anterior, you see on the left, anterior vaginal wall, anterior compartment, the apical or the middle compartment, and the posterior vaginal wall or the posterior compartment, and the last one is the perineal body defect. So anterior vaginal wall, it can be cystosil, it can be central, posterior or lateral, or it can be a combined one. Urethrosil is uncommon, and along with this, there will be enterosil and rectosil. So the age-old classification I was telling you is first degree, second degree, third degree, and fourth degree. So it is a saw versus malpass. One is 3 degrees and one is 4 degrees. The first degree is usually inside the, I have already told you, but they have combinedly, it is still inside the introitus, or they have left their introitus, is one first degree. Second and third follows it. So understandable for apical and central defect, but it lacks site-specific indication. And I have already told there are two anatomical landmarks. I have told about the ischial spine. The other one is the hymen. So, new classification or the update classification, what to say, is two systems: Baden-Walker halfway system and POP-Q, which is called pelvic organ prolapse quantification classification or POP-Q classification. See, Baden-Walker halfway system is user friendly. It is easy to record. It maximizes the amount of detail that can be recorded in a brief space, but it lacks site specific defect, it lacks quantification. So, if you see Baden-Walker halfway system, the basis is there are 6 defined sites in the vagina. What are they? 2 anterior, 2 superior, and 2 posterior. The anterior one is the urethral and vesical. The superior or middle one is the uterine and cul-de-sac, and posterior is rectal and perineal. So the extent of the prolapse will be 0, 1, -1, -2, -3, -4. So reference point are again to ischial spine and hymen. So perineum is graded difficulty. As perineal tear occurs, the perineum is lost. So the strength, how do you measure it? Is the levator contraction, which will show you the position of this. This is the picture description of Baden-Walker halfway system. You can see the cervix cuff. It is the cervix and the cuff is the ischial spine over this position. Remember, this is the vagina and this is position 0. And it comes down the 1, then comes 2, and the level of the hymen, and this is called 3 and 4. The maximum descent, what we called as which is similar as the stage 4 of Malpass classification is this, which we called as procedencia. So I will go in detail about POP-Q classification because many have requested me to speak in detail about it. So POP-Q classification, we want to say about the evolution, why there is a need of POP-Q classification, and what is the classification system itself. See, the evolution is there was a need of standardization of terminology. See, 3 societies, International Continent Society, American Urogynec Society or AUGUS, and Society of Gynecologic Surgeons SGS. These three societies sat together and standardized the terminologies for a POP-Q classification. Why? What was the need of POP-Q classification? See, there was a need for quantifying it. You have to, I see, saw and malpass, you saw that you have your own system, and for you it can be stage 1 or stage 2. For me, it can be only stage 1. So if I explain you, you can easy to understand, but you cannot quantify it. There is a need for site specific and need for objective assessment, and it is better communication and understandable. If you and I understand, Asha sitting in Indore can understand what I mean. And measurements are actual rather than arbitrary. Are you able to hear me? Please say yes.
Yes, sir.
Hello?
Yes, sir.
Yes,
Yes,
yes.
sir.
Hello?
Yes, sir.
I'm not getting any feedback from anybody.
No, sir. We are
Hello?
spellbound.
Rajini Sahu and Vidya Thobbi, madam, I am seeing, but I'm not hearing anything from
Sir,
you.
sir, I'm very much listening to your wonderful talk.
Okay, madam. Thank you. Thank you.
A very,
So,
very nice presentation, sir. I've heard so many, but it's a very good classification.
thank you. Thank you so much. So, why there was a need? So, the all three society, they sat together. They wanted to quantify the prolapse. Maybe you can say it is more of academic purpose, more for the paperwork, but believe me, it is more rational and more scientific. We do not use POP-Q classification because we do not go through it. So they compare the outcome of surgical repair. Before the surgery, the situation is this, and after the surgery, the situation is. There is a inter-individual reliability. So it is same for all if you say this. And standards in written publication and scientific presentation, which is the main thing, but it is little complicated. So it has got strength and weakness. You see, we have SWOT, SWOT. S is strength, W is weakness, O for opportunity, and T for threat. So strength, weakness. So the strength is, it is more scientific and it is reproducible. You can understand what I say. The weakness is that it appears more complex. So easy to understand, difficult to practice, or difficult to understand, easy to practice. So now let's go to the system itself. So there are two reference points, the two anterior wall. I will go to the picture after this. So you can say it is AA and BA. Two posterior wall, it is AP and BP, and two apical is C and D. So measurement from the proximal hymen, it will be minus, and positive distal to hymen. Above hymen, it is minus, and below hymen, it is plus. So three distinct measurement, GH, genital hiatus, PB, TVL, and grid system of presentation. So measurements are done in centimeters. So hymen is the fixed point of reference. Plane of hymen is defined as 0. Above I have told it is negative number, below it is positive number. So I told you 3 points. Anterior, you can see here, where is my cursor? This is AA and this is BA. I'll just see it, then we'll go. It's the anterior part of the cervix. This is the vaginal canal. This is the bladder, and the urethra is the picture. This is the uterus and the vaginal canal. This is the rectum and intestine in the back. So you can see similarly anterior to this is AP and BA is BP. And this is the total vaginal length, TVL. So this is the vagina. Take from the cervix point, and the introitus, this is TVL. Second thing, this is the perineal body, this is the perineal PB and genital hiatus. So this is the hymen, and this is minus in centimeter, this is plus in centimeter. I think this is least I can say you. The three measurement I told is the genital hiatus, from the middle of the urethra to the middle of the vaginal canal, genital hiatus. Perineal body is this PB, the length, and the posterior to this, the middle of the vagina to this middle of the anal canal or the perineal body is this. And I have told you about the total vaginal length or TVL. So I will able to go on saying GH means genital hiatus, PB means perineal body, and TVL. So now point A. So I'll go back again. I'll say point A, it can be anterior and posterior. So it is anatomically defined in the midline of the anterior and posterior vaginal wall. Again, in the midline of the anterior and the posterior vaginal wall, point A. This is the vaginal wall, anterior vaginal wall AA and AP. And then comes the 3 centimeter proximal to external urethral meatus or urethra or hymen. So the range of the position will be -3 to +3. So define points. AA is anterior, AP is posterior. The midline of the anterior vaginal wall and posterior vaginal wall. You see the midline of the anterior vaginal wall 3 centimeter above external urethral meatus, the approximate location of urethrovesical junction. This is approximately the urethrovesical junction, and that is called the AA. The midline of the posterior vaginal wall, midline of the posterior vaginal wall. Can you see my cursor moving? Yes. So the midline of the posterior vaginal wall, 3 centimeter proximal to the hymen. Hymen is here. You can see the hymen is here, 3 centimeter above is AP. So now the point B is not fixed like anterior, because point B is variable, or we say it is dynamic. It is the most distal point. I can go back. It is the most distal position of any upper vaginal wall between anterior or posterior fornix or cuff and A. Again, this BA and B posterior, this is the posterior one, and with descent this can change. So the value again 3 centimeter in absence of prolapse. So BA is anterior, BP is posterior. So these are all variable points, and most distal portion of any part of anterior or posterior vaginal wall from the vaginal cuff or cervix or point A. See, BA and BP, they are subjected to change. With descent, the BA and BP will change. If I draw a diagram like this, the line diagram, AA will be somewhere here, BA will be here, C is in the center, BP is here, and AP is here. So you can also say +3 to -3. So difference between A and B, A is a fixed point 3 centimeter apart from the hymen, anterior or posterior. B is the most dependent part of the compartment, anterior and posterior. So genital hiatus or GH, it is the middle of the external urethral meatus to the posterior hymen. The posterior hymen. So this is called genital hiatus. And cervix or the cuff, it is the most distal part. You can see the cervix here. It is the most distal part, distal edge of the cervix or leading edge of the vaginal cuff. This is the cervix, and this is the vaginal cuff which is there, which we called as the hysterectomy scar. So D is pouch of Douglas. So posterior fornix or pouch of Douglas is called D. And this is just point C is anterior, point D is posterior. It represents the level of the uterosacral ligament attachment posterior to the cervix. If there is no cervix, there will be no D. Okay. So now the perineal body, the posterior margin of the genital hiatus to mid-anal opening is the PB or the perineal body. It extends to the posterior margin of genital hiatus, the midline of the vagina, and the mid-anal opening. This will be PB or the perineal body. So total vaginal length is the greatest depth of vagina in centimeters. So this will be point D in a preoperative case to the hymen, and this will be measured in centimeter. C and D in normal position. So measurement should be done without straining. That is very much important. So now we can stage the pelvic organ prolapse according to the POPQ system. Stage 0, there is no prolapse. AA, BA, AP and BP are all in -3 position, 3 centimeter above the hymen. C or D, anterior is C, D is posterior, between total vaginal length and less than 2 centimeter. Stage 1 will be now most distal portion more than 1 centimeter above the level of the hymen. And stage 2 will be less than 1 centimeter proximal or distal to the plane of hymen. And stage 3 is more than 1 centimeter below the plane of the hymen. And stage 4 will be complete eversion, distal portion, at least the total vaginal length more than 2 centimeter. So the physical examination technique, you see, the protrusion of the vaginal wall should be examined during straining. So traction causes no further descent. So second thing, it subject confirms the size of the prolapse, and standing straining examination confirms the full extent of the prolapse. So that's the physical examination testing. Now the grid AA, BA, C, GH, PB, TVL, and that is the grid which you want to do. So physical examination technique, the position of the subject, ideally in the standing position, or some people use lithotomy, some people will lateral position, preferably left lateral position. So type of the vaginal speculum, some use Ekuskos, some use Sim speculum. So I ask the patient to strain or cough, and normally the bladder should remain empty to see this. But if you want to see the extent of the cystocele, bladder may be full. So method of quantitative measurement can be done. Actually, there is a measuring tape or a scale. I will show the scale over here. So the point and landmark a POPQ system of examination I have already shown, and this is the entire cyst and the picture, and this picture will be given to you, and you of the measurement of POPQ system will be like this. I will go back again like this. So the entire, and you can graphically measure if the A is -3, BA is -3, C is -6. So this way you can do a measurement and you can show. I think I will stop short here regarding the classification and the staging. I think you still require a little more elaboration for this. So I would like to conclude here. The standardization and uniformity of classification is necessary. That is felt by the 3 societies I mentioned. Staging is important for appropriate surgical technique. It should be simple, user-friendly and reproducible, which really lacks here. So it is more objective rather than subjective, estimate rather than guesstimate. So I will not go to the surgical goal because Samir is going to say, but in all cases, please remember that maximum restoration of anatomy, maximizing the function, addressing the urinary and defecating problem, promoting fertility potential, minimizing complication and preventing recurrence. These are the surgical gloves, and with these words, I say thank
Yes,
you
sir.
and conclude my presentation.
No, sir, don't stop sharing. Don't stop sharing. I want
I'll
you to
Go
explain.
back, go back,
Go back one slide, sir, and
go back.
explain how on a patient that staging is done. Because that staging that you showed, it is not clear in my head.
Yes,
This
I
one.
do that.
How this was done. This is what I need to understand.
Yes. So you have to take a patient.
Hmm.
I have to go back again. Let's see here. This is a normal position.
Okay.
This is a normal position.
Hmm.
And here remains the hymen. Normally there is no descent over here. So this is a system which we called as stage 0. C and C -3 position, meaning 3 centimeter above, and there is no descent anteriorly and posteriorly, and that is why you say. Now, when you come next, the uterus will come down. Uterus will come down. Please remember, from this C will be little somewhere here. The anterior wall and the posterior wall will remain. Again, I have to show you. So this is stage 0. Can you understand? There is no problem here.
Yes, sir.
Yes. Now that I will like to say, moment ଟିକେ ଡେରି ହେବ ମୁଁ ଟିକେ ପରେ କହୁଛି. See, now that what we say, if I say that this is the perineal body, sorry, symphysis pubis here, picture. This is the one, and now that you can see, the uterus has come down to below, and the position of, how do I have to show, make another picture to show you. So if I give it a chalk and a duster, I can draw and so along with this, you can think another position, keep another picture of stage 1 first degree prolapse, where the cervix has descended further and the rest of the things are normal. So this will be somewhere, it will be less than this. I'll show you this. Yes. See, read this. This is what picture I have shown you. Stage 0. There is no prolapse. AA, BA, AP, all are -3 position. 3 centimeter minus. C and D between total vaginal length, where the total vaginal length will be less than 2 centimeter. Now uterus has come below. If it has come below, the most distal portion will be more than 1 centimeter above the level of the hymen. Read this. I am going down. Right.
Got it, sir. Got it. But it is so complicated.
I know. As because I was asked to present this, I have to
Yes, sir.
read it, and I made it little simple for you to understand.
Thank you, sir. Thank you.
Right. So I will go back. Next time when we meet in person, or we give a chalk and duster in the
it
blackboard,
will be
I
better.
will
Yeah.
make
Then it
4
will be more.
pictures. I will make 4 pictures and quantify it. Can you understand? Then will you understand?
Okay, sir.
And
Okay, sir.
I think for the next presentation, I will bring the 4 pictures and quantify it side by side, so that this
Becomes easy for us to understand.
becomes easy for this one. One picture for stage 1, one picture for stage 2, one for stage 3, and stage 4. The 4 pictures I will like to do. Stage 0 you have already seen, right?
Yes,
So,
sir. Thank you, sir.
I think I will conclude here, and I think I have not make you understand fully. So give me one more session
Yes,
over
sir.
here, and we can do that.
Thank
Right?
you, sir. Thank you, sir. Over to you, Chairpersons, Dr. Akshay, Dr.
Yes, madam.
Savita, ma'am.
Yeah, please offer your comments, sir. Yeah.
Patnaik sir, to hear from Patnaik sir is like we are reading a textbook. It was an excellent, of course, as senior madam have said, it is slight difficult to understand, but you tried to make it simplified whatever base that you could. We appreciate.
I wanted 4 more pictures to make my presentation complete. For
Yes.
one picture for stage 1, 2, 3, 4. Next time I will be having this. Okay.
You did whatever base that you could, and we really appreciate that. But
Thank
to
you.
be very honest, it was like reading a textbook. That just extraordinary explanation. Thank you, sir. Thank you so much. Madam, over to Savita, madam.
Thank you, sir. It
Thank
is
you.
always, you always try to make the things simplified, and this time also, although it is very difficult topic, but you simplified in it is very much simplified and try to make it
एक बार
understandable
घुसिए
to all
madam,
of
it is
us.
understood. It is not
We
that,
will
it is
have
only to,
one
yes.
more,
Yeah, yeah.
yeah,
Chalo,
one more
would
talk
you like
from
to
you
say
so
something?
that it will be more clear to all of us. Thank you, sir. Thank you so much, sir.
Thank you.
Hara sir, only you could have done justice to the
Thank-
topic. So that is why I called you, because I have heard it many times. थोड़ा ऊपर से जाता है. So I needed to understand it myself. Thank you so much, sir. Thank you. Dr. Vidya, we have introduced you. If you would please say a
Yes,
few
yes.
words.
Yeah, Asha, your Searchlight is really amazing. I usually attend few of your webinars in the past, and this one is the unique one. What I feel. I'm really thankful for inviting and the people you have invited as speakers. You choose them very meticulously. And just now we heard Dr. Hara, and definitely yes, this prolapse and its classification, he has really done a wonderful means simplified way of classification. We always teach our students, but even then they always make mistakes in the exams. And if the demonstration is on the live patient, definitely yes, but we can make simple small videos, and we can definitely show them. Of course, we have to take a permission for this photography and all. But I must say that Asha is very special candidate for Food, Drugs and Medical Surgical Equipment Committee chair, and I request all the societies and everyone to vote for her in coming election. All the best, Asha, and definitely we look forward to a great tenure of yours. Thank you. Thank you, Hara. Thank you, Hara, for a nice
Thank you,
talk.
madam.
Yeah. I am eager to listen to Dr. Samir Pradhan and other speakers as well. Thank you.
Hara sir, this is a promise that I will make you explain it again with all 4, 6
Asha will not
pages.
leave you,
I will
Dr.
not
Hara.
leave you. So
I have learned this, that next time when I present, I will have 4 more pictures along with the stages. I will do this. I will make it a grid so that this you can understand in the grid system, so that it will easy to explain. ठीक है?
ठीक है sir, ठीक है. So now I would like to introduce Dr. Bhagyashri Sudhir Ranjwan. She is the Honorary Secretary of Aurangabad Obstetric Gynec Society, Honorary Treasurer of AOGS 19 to 24, Managing Committee Member, and Honorary Treasurer. She has contributed chapters on internal iliac artery ligation and presented papers, has been a faculty, and she is a person who actually follows Searchlight. So welcome, Dr. Bhagyashri ma'am. Dr. Himanshu Pannot, he is the Secretary of Bhavnagar Obstetric Gynec Society, and Dr. Kamna Datta, the most dynamic Secretary of Association of Obstetricians and Gynecologists of Delhi. She is a professor at AB WIMS and Dr. RML Hospital. Her areas of interest are high-risk pregnancy and oncology, and has multiple publications in national and international journals. Dr. Kamna, I would request you to please introduce Dr. Samir Pradhan, sir.
Thank you and congratulations, Asha ma'am, and wishing you all the best for the upcoming elections. I'm sure you are a strong, very strong candidate. And with this, it's my pleasure and privilege to introduce Dr. Samir Pradhan. Sir is Director of Samarth Maternity Nursing Home from Mumbai. He is his special interest lies in vaginal surgeries, high risk obstetrics, and laparoscopy. He's had best video on vaginal surgery in 2023, has been moderator and faculty in live workshops, and is also the joint secretary for Maharashtra chapter SOVSI. So over to you, Dr. Pradhan, and we are eager to listen to you.
Thank you very much, Dr. Asha Jain, madam, and your team Searchlight for this honor. And I will just share my presentation. So is my full screen visible?
Yes, sir. Yes, sir.
Yeah, 1 sec. Just give me 2 minutes. I want to minimize this part. Okay, never mind. That minimization I should have done beforehand. So thank you, Dr. Kamna madam, for this kind words of introduction. And I try to learn PopQ so many times, but since I am in a private practice, I don't apply it anytime. Even recently, Dr. Datta from Pune tried to teach. But as Dr. Haraprasad Patnaik said, he has to now literally show us videos of live cases and then how the PopQ. And I think the more application of it is mainly for our publications, which we Indians are lacking. Like when I was reading the literature, all the foreign textbooks have no mention of our conservative surgeries at all. So my topic today, sir, has made quite easy. It is on conservative surgeries for prolapse. The aims, as sir had clearly mentioned, is to relieve the symptoms, restore the anatomy to normal, restore the functions to normal, prevent recurrence in the future, maintain the childbearing potential, and maintain the menstrual function. There are certain challenges to conservative surgeries. The repair of prolapse should not hamper the fertility, and the surgery must not hamper the course of normal deliveries. And repair must not give way after the childbirth, and it should not cause any recurrence. So the abdominal sling operations were designed to overcome all these challenges. So just elaborating all the abdominal sling conservative operations. By conservation, we mean that the uterus or the end organ is not removed. So the surgery is done with the abdominal route. And nowadays, this same surgeries can be done by the laparoscopy route or the sling surgeries. They are mainly, as sir mentioned, the suspension of the upper part. So it is by Purandar's cervicopexy, Shirodkar's sling, Khanna's modification of Dr. Shirodkar's sling, Sonawala's modification, then recently sacral hysteropexy, Dr. Virkut's composite sling, Dr. Joshi's sling surgery, which was modified by Dr. Nuegontar, and he has done a hystopectopexy. And the good old vaginal surgeries where the uterus is not removed are the anterior colporrhaphy for a cystocele, a posterior colpoperineorrhaphy for a rectocele, Fothergill's repair, which was done by Donald and Fothergill at Manchester. It's called the Manchester operation. Shirodkar's modification of Fothergill's called the Shirodkar's uterosacral advancement. Dr. Nadkarni from Gujarat had done a very nice surgery called Nadkarni's sleeve surgery. Sacrospinous hysteropexy is done by quite a few centers in UK. And this other three operations are usually described for very old patients, but they come under conservative surgery because even in this, the uterus is not removed. They are the Lefort colpoclysis, Goodall-Powers modification of Lefort colpoclysis, and Dani stitch or introital tightening. The principles, as Dr. Hara Patnaik had showed, we know the level 1 support is the attachment, suspension by the uterosacral cardinal ligament complex called the Delancey's level 1 support. And the abdominal surgeries aim at restoring the level 1 support by the suspensory mechanism. Whereas the vaginal surgeries aim in the attachment, that is restoring the level 2 support of the pubo-vesico-cervical fascia anteriorly and the rectovaginal denonvillous fascia by a plication and a reattachment mechanism. The lower support, that is fusion, which Sir mentioned, can be done by the levator levateroplasty for a posterior the genital hiatus and the perineal body reconstruction. And if there is incontinence, one can always do a retropubic tension-free vaginal tape or a transobturator tape. But I am not going to cover this in this particular talk. Coming to the sling operations, the easiest surgery to be done is Purandare's cervicopexy. It was described originally by Dr. B.N. Purandare way back in 1965, wherein the rectus sheath strips were made from the rectus sheath, and they were anchored to the anterior part of isthmus through the 2 leaves of broad ligament. Later on, this rectus sheath was replaced by polyester tape. It was earlier made by Ethicon. It was called Mercilin, and nowadays we get it done by Healthium. It is called True Bond tape. It is actually a type 3 mesh. The Purandare cervicopexy was a dynamic support. What it meant was when there is increased intra-abdominal pressure during coughing, the sling used to brace the cervix towards the anterior abdominal wall. But there was a disadvantage that the UV fold used to get obliterated. And since the anterior compartment was strengthened, there was a risk of enterocele, that is the posterior compartment defect. There were certain modifications of Purandare's cervicopexy. Dr. Praveen Matre and Dr. V.N. Purandare, the younger brother of Dr. B.N. Purandare, they used the Mercilin tape for the first time, and they viewed the tape in the rectus sheath on both the sides. And the ends of the tape, instead of being anchored anteriorly, were passed through a avascular area in the broad ligament and anchored posteriorly to the isthmus where the uterosacrals are anchored, making this pexy more anatomical. Dr. Prashant Mangeshikar performed this surgery laparoscopically, I think way back in 1994. And I have worked with Dr. Amarnath G. Bhide in Vadia as a registrar in 1997, where Sir has done this vaginolaparoscopic approach, and I found it quite convenient. And I'm using it quite a lot for my nulliparous prolapse cases since the last 25 years. So I'd like to enumerate the steps in detail because this is something which I have done and it is something which everybody can easily practice. One does the vaginal dissection in the vesico-cervical space till the level of isthmus. This is the same dissection which we do for a modified Shirodkar circlage for cervical incompetence. The opening of the anterior peritoneum is not required. Then the polyester tape, which has a needle on one side, is driven through the cervical tissue. One can take an additional stitch to fix the center part of the tape, either with a Prolene or a Vicryl. Then one inserts the 10 mm laparoscope through the umbilical port. With this, one has to see the exit of both the round ligaments. So you will see the round ligaments exiting laterally where our ends of the pharyngeal incision are. Just make a 3 cm incision on both the sides of the abdomen at this level and dissect layer by layer as one used to dissect for a mini laparotomy tubal ligation and reach up to the level of rectus sheath. Once you go to the level of rectus sheath, you take a long hemostat or you can take a Berkeley bony forceps, which was used for Gilliam's bento suspension operation long time back. And you can see this hemostat coming inside retroperitoneally to the laparoscope. And this hemostat is driven between the two leaves of broad ligament, and it comes anteriorly to the area of the isthmus. This tip is felt vaginally, and then one just pierces it, holds the tape, and retrieves it between the two leaves of broad ligament and retrieves it in that space lateral to the rectus abdominis muscle. The same process is repeated on the other side, and then the vaginal mucosa is sutured. Then one adjusts the tension so that the cervix goes above the level of ischial spine. That is the one landmark which Dr. Haraprasad Patnaik sir mentioned. And then this tape is fixed to the rectus sheath on the under surface, and the abdomen is closed in layers. If after this home surgery, the uterus does not become anteverted and it remains in the mid position, there is a chance for recurrence. So one can additionally put two accessory ports, and with proline number 0, do round ligament plication, which will shorten the round ligament and cause anteflexion of the uterus. Dr. Shirodkar had described his sling surgery, Dr. V.N. Shirodkar from Mumbai, JJ Hospital, way back in 1958. And it is so far the most anatomical repair for a nulliparous prolapse. Dr. Shirodkar was a surgeon, and he used to use fascia lata strips, and they were anchored to the posterior part of isthmus where the uterosacrals are attached, and then to the sacral promontory to reinforce the weak uterosacral ligaments, that is Delancey level 1 support. Later on, this fascia lata was replaced by the polyester tape, and this sling can be used in cases of poor muscle tone or a defective rectus sheath or a failed cervicopexy. I have done quite a few Shirodkar sling by the open technique. The laparoscopy technique requires much more better intracorporeal suturing techniques. The open technique, the steps which I want to enumerate, which are taken from the Shirodkar's monogram, is a midline vertical incision. One should pack the bowels away. One can use a malleable retractor and keep it, and then the ends of the malleable retractor are kept at place by the self-retaining Barfor's retractor. This gives us the exposure like a laparoscopy, and the bowels don't keep on coming in our way. Then one takes a long plain vascular forceps and cuts the peritoneum over the sacral promontory. One has to be on the inferior and the right side to avoid the common iliac vein and the sympathetic plexus, which are on the superior aspect. One exposes the anterior longitudinal ligament. It is a shiny ligament, and then the tape is fixed to the cervix just above the level of insertion of the uterosacral ligaments. Then one takes stay sutures with linen or silk on the anterior longitudinal ligament. One has to safeguard few veins there. And one should not go very medially because there is a middle sacral artery, and there are the emissary veins which are the bleeding from which is very difficult to control. Dr. Shirodkar used the Shirodkar sling needle, but if you don't have it, one can always pass a long hemostat retroperitoneally medial to the right ureter on the right side till the right uterosacral ligament, retrieve the tape and get it to the anterior longitudinal ligament. On the left side, one cannot do the whole procedure because there is the sigmoid colon. One has to, on the left side, use the left side needle or the long hemostat and retrieve the tape only till the left psoas major muscle. Then use another tape and form a loop through the left psoas major muscle. While taking this loop, one has to safeguard the genitofemoral nerve, and the tip of the needle should not hit against the left external iliac vein while withdrawing it. That was the tip my sir told me, because sometimes there have been instances where the eye of the needle, when you're trying to withdraw, just slash the external iliac vein and cause potential bleeding. One always should have vascular clamps when one is doing this surgery ready on the table. Then the tape is passed through the loop. This safeguards the tape from compressing the sigmoid colon on the left side, which could otherwise cause intestinal obstruction. Then one passes the hemostat from left side from the sacral promontory to the rectorectal holy plane, below the sigmoid colon until the left side of the psoas major muscle and then retrieves the tape. One has to really do this dissection to understand that there is nothing behind the rectum, and that's why called the holy plane. When I had gone for cadaver training dissection by IAGE, Dr. Puntambekar made me do this dissection, and that is how the confidence develops. Then this tape is fixed to the anterolateral ligament with permanent sutures. The traction should be adequate to make the uterus an abdominal organ, but one has to allow 4-finger breadth space in the false pelvis so as to allow the sigmoid colon to distend. One always sutures the peritoneum over the anterolateral ligament and the psoas major muscle, and the abdomen is closed in layers after confirming hemostasis. This surgery was difficult, and so it was modified by Dr. Brigadier Khanna from Pune in 1972, wherein the polyester tape was anchored to the posterior part as Dr. Shirodkar did, but it was fixed to a bony support anteriorly, which is the anterior superior iliac spine. And Dr. Rustum Sonawala sir did this surgery only on the right side and also achieved sufficient correction of nulliparous prolapse. Recently, since last 20 years, this surgery has been done laparoscopically. It was first demonstrated in 1998 by Dr. Nita Varti, and Dr. Pandit Paraskar, the past president of IIG, used to routinely perform these surgeries. Laparoscopically, once you are conversant with intracorporeal suturing, the advantage is that it is a minimal invasive surgery. So the difficulty encountered in a laparotomy while operating in a depth is taken care of by laparoscopy because you can go near the structures and get a good magnification. Since the layers of abdomen are not open, bowel is not handled, there is less post-op pain, less post-op ileus, faster recovery, and magnification gives more precision, especially with the high definition and nowadays with the 3D laparoscopes. And there is easy access in depth. However, even this sling surgeries has limitations. The uterocervical length should be less than 5 inches, and there should not be an additional cystorectocele, or it should be very minimal. The weak ligaments can cause recurrence, and this can be overcome by using a polyester tape. Since the sling is a posterior sling, it can sometimes cause retroversion, and that's why round ligament plication may be required. The anterior slings, namely the Khanna and the Purandare, as I mentioned earlier, can cause enterocele. So preemptively, one can do a Moshkovitz or a Halbans repair when one is contemplating these surgeries. But the gold standard nowadays is sacral hystropexy. It is an extrapolation of sacral colpopexy. It can be done by open technique or laparoscopy. It was first described by Swain, and then Constantini et al. Conducted a controlled trial using polypropylene monofilament macroporous mesh. Why monofilament? To prevent infection. The Vipro mesh, Vicryl with proline, was out because it caused a lot of infection. And we cannot use the hernia mesh, mind you. We have to use a macroporous mesh. The advantage of mesh is the fibroblasts have to grow through the mesh, the pores of the mesh, and substitute the defective collagen, which is the commonest cause of the defect. So it overcomes the existing facial weakness. The fixation is to a suitable point, a fixed point in the pelvis. It overcomes the effects of facial detachment from the original structures, reduces the risk of recurrence, and as against colpopexy, where the risk of mesh erosion is there, in a hystropexy, since the uterus is there, the erosion is almost negligible, almost 0%. The steps, quickly enumerating them, is one has to expose the anterolateral ligament as earlier and use a soft macroporous polypropylene mesh cut in a Y-shaped manner. The UV fold is dissected till the isthmus. One limb of the Y-shaped mesh is fixed posteriorly at the level of uterosacral, and the other limb is brought out through the avascular space, which I had mentioned how Dr. Mhatre Purandare did in Purandare cervicopexy, lateral to the uterines. And then it is brought anteriorly and fixed to the level of isthmus. Optimal traction is made given to make the uterus an abdominal organ, and then the stem of the Y is fixed to the anterior longitudinal ligament. The excess mesh is cut, but the mesh has to be peritonized, else it causes severe bowel adhesions, which can cause intestinal obstruction. These are the diagrammatic representations of all the steps which I just mentioned. And the advantage is it is a strong repair. As I said earlier, the fibroblasts grow through the pores. The vaginal length is not compromised. So it does not interfere with the patient's sexual life. The uterine axis is unaltered and antiversion is maintained. However, one has to have a sufficient learning curve for this, else one can cause torrential hemorrhage. Bowel and ureter injuries can be done if the planes are not respected. Earlier, they used to fix the mesh by tackers, but it can sometimes cause bone infections or severe backache, or osteomyelitis, for which the tackers had to be removed. And it was few of my friends have done this, and it is a thankless job, and the patient keeps cursing you. In the sacral colpopexy, not so much in the hystopexy, the mesh infection, exposure and extrusion are problems. So nowadays, even sometimes, even if a hysterectomy is done, they do a subtotal hysterectomy and then do the mesh fixation to the cervix. If while dissection, the mesh migrates towards the inferior hypogastric nerve, which is there in the Okabayashi's medial pararectal space, then the patient has severe bowel and bladder function. So one has to really know this dissection very well. There are certain modifications of this surgery if there is a concomitant cystocele or for cystocele mainly, or even for posterior defect. Here they have dissected and anteriorly they have put the mesh up to the level of the UV junction to take care of the mesh. Then the mesh is Y-shaped. The two Ys go down next to the urethra and the stem is at the isthmus. And there is one more plain mesh posteriorly also. But this meshes prevent the cervical dilatation. So the patient has to go for cesarean section. So there was one more modification which I found in the recent advances of North America. Here they made a curvilinear mesh and put it only anteriorly, so it does not cause obstruction. Dr. Virkud, my teacher at Bandra Bhaba in 1999, devised a composite sling where he did the Shirodkar's type of sling on the right side and a Purandare's pexy on the left side. But the uterus got a tilt, a short dextro rotation, because of the right was pulled behind and the left was anterior. So that is why he did the plication of the uterosacral ligament with a non-absorbable suture material. It is easy to perform, gives double support, bony plus dynamic. Tape is posterior, hence no risk during LACS. No risk of enterocele, unlike pectopexy or unlike cervicopexy. And no risk of injury to sigmoid colon, left ureter and left major vessels, because that part is completely omitted. Dr. Vivek Joshi had a lot of series of doing open burst repair for genuine stress incontinence, and he extrapolated his dissection to fix the tape anteriorly to the uterus at the level of isthmus, but the tape was then fixed to the iliopectineal ligament of Cooper, which is used for burst colposuspension. And subsequently, Noy Gunther from Germany did this surgery laparoscopically. Initially, it was developed to take the bowel complications of sacral colpopexy away, so it was done for wall prolapse, but later on it was extrapolated and is now called hystopectopexy. Sir had demonstrated it in one of the live webinars of IGE. He uses this polyvinyl difluoroethylene mesh PVDF, which is much less, it causes less adhesions. Dissection is done in the Cooper's ligament till the level of corona mortis. Corona mortis is a vein which connects the obturator vein to the external iliac vein. And one can cauterize this vein because one has to go really deep there. And only then one reaches the level of S2 and then maintain the physiological axis of the upper vagina horizontally. There are no risk of bowel complications because the inferior hypogastric nerve is not encountered in these cases. Coming to the vaginal surgeries, I will not go to the anterocolporaphy. It is a pretty standard procedure. Only thing I would like to inform is nowadays we can do there's a continuous argument between the laparoscopic surgeons and the vaginal surgeons that the laparoscopic surgeons blame the vaginal surgeons that we compromise the length of vagina. So nowadays I learned from one of my colleagues, senior colleagues who is a urogynec in UK, that they do the anterior repair without excising the vaginal flaps, wherein one can do the dissection and just keep the vagina intact and attach the pubo-vesico-cervical fascia, which has got detached from the its attachment to the pericervical rim, and it has got retracted and it has to be reattached. And then that whatever plication we used to do, it can be done without excising the vaginal flaps. Sometimes one has to also rule out a lateral or a rotatory cystocele. So that lateral sulcus has to be seen while examining the patient in the OPD. The lateral sulcus is seen, it means the lateral cystocele is not there. But if the sulcus is disappeared, it means during the internal rotation that head and during gestation, it has avulsed the pubo-vesico-cervical fascia from the arcus tendinous fascia pelvis, and the defect it has healed by fibrosis. And that when you do a central correction, you further increase this defect, and then the patient comes with a recurrence. So if a lateral cystocele is there, it can be repaired vaginally, but one requires deep instruments like one is uses for sacrospinous fixation, or it can be done laparoscopically also. Now coming to Fothergill's repair, I have done only few cases of this. It was described by Donald and then modified by Fothergill's. Fothergill's was student of Donald and done in Manchester, United Kingdom. The steps, there are few photos from the live surgery of AFG. The surgery was done by Dr. Mohan Gadam. In this AFG live workshops were done by my sir, Dr. Sarogi sir, who has taught us all these vaginal surgeries. Patient was in lithotomy position. One does a dilatation till number 10 and a curettage. This number 10 dilatation is important that one has to place the Sturm-Dorf suture to cover the transected cervix. Cervix is pulled down, a circular incision is taken, the anterior and posterior flaps are created. There are 4 Fothergill's points. The anterior one is below the urethral meatus, posterior the apex at the pouch of Douglas, and 2 lateral as per the elongation. The cardinal McIndore's ligament are clamped, cut, and mobilized. One has to really make them free. Long. Pardon me? Hello. The descending cervical artery on each side is ligated with number 1 vicryl above the level of intended amputation. Cervix is amputated. The posterior Sturm-Dorf suture is taken and the ends are kept long. Then one does the A repair by the convention, not the conventional technique. Here we don't excise the vagina because we require the vagina for the Sturm-Dorf suture. Dr. Schanbach from Sion has used to do this routinely. Then the cardinal ligaments are advanced over the anterior lip of cervix, fixed with vicryl sutures. The anterior Sturm-Dorf suture is taken and tied. Lateral sutures are taken to cover the raw area. Then the posterior Sturm-Dorf suture, which was taken earlier, and the ends were kept long, that is tied, and the P repair is then done. The limitations are, since the cervix is amputated, it can cause complications like habitual second trimester abortions, preterm deliveries, pre-labor rupture of membranes, fibrosis, cervical dystocia, and recurrence. And it cannot correct a complete eversion of vagina. So Dr. Shirodkar did something called Shirodkar's uterosacral advancement, wherein this cervical amputation was not done. The posterior pouch was opened. In Fothergill's, we take the McIndore's ligament, so the P pouch is not open. Here, sir, use the more scientific uterosacral ligaments instead of the cardinal ligaments, and for this, one has to open the P pouch. It is more physiological, and it also, when the uterosacrals are taken anteriorly, they get shortened. And since there is no amputation, it avoids cervical incompetence. I would just like to share one case which I did way back in 2007, a nulliparous prolapse. These are the operative notes and this. So why I will tell you why I'm sharing this case. The patient was just married and she told me she went to hang the clothes in the bathroom on the balcony and she fell and the whole uterus came out. It was just a story to cover up the prolapse. And she had 3rd degree prolapse with a UCL of 4.5 inches. So I knew that laparoscopic pudendales plexi would suffice, but the cervix, that long cervix will be hanging outside. So I raised the vaginal flaps, P pouch was opened. I decided to use the uterosacral ligaments. clamp, cut and transfixed them. Then I took the descending cervical vessels as we taken for the gills and did only amputation of the distal 2 inches. Then I fixed the muscle tape to the anterior lip, did the lap assisted pexy as I was doing earlier. Then I did the Shirotka's uterosacral advancement, took the Sturmdorf sutures, pulled the tape, and then fixed to the rectus sheath. Patient came for suture removal and then had no follow-up. However, after almost 16 years, one of my friends, Dr. Ashutosh Asgaonkar, sent me this WhatsApp message. This patient was pregnant, anti-scan showed a short cervix. He had a difficulty doing a Shirotka's cerclage, and the patient, it was done, and the patient had an uneventful delivery. So that combination surgery stayed for almost 16 years. Of course, I don't know after the delivery what would have happened, but he did an elective cesarean, obviously, the patient. And in 2023, Dr. Kurian Joseph did mention that this combination approaches are sometimes required for nulliparous prolapse when the elongation is too long. Nadkarni had developed very nice surgery, which I have assisted Dr. Sarogi sir once, but it's a very difficult surgery. Only the central part of the core of the cervix is removed and the whole descending cervical vessel has to be separated from with the sheath. It can be combined with the Shirotka's uterosacral advancement and it does not cause crumpling of the cervix. But since it was a difficult surgery, Dr. Geeta Niyogi madam from Sion Hospital and then in Somai Hospital used to do this routinely, but it is not shown in much conferences. Sacrospinous hystopexy, I don't have experience, but it is mentioned and done in UK. I do a lot of sacrospinous colpopexy for wall prolapse, but the steps are more or less similar. One does a high colpotomy, perforates the right rectal pillar to enter from the rectovaginal space to the right pararectal space, exposes the right sacrospinous ligament. One requires a breast skin aurational retractor to retract the bladder or the rectum medially. Narrow but long devers to retract the anterior part, and a Landon's which is angulated to retract the lateral part. Find the ischial spine and see the ligament going dorsally and medially. One has to be 2 finger breadth away from the ischial spine to protect the internal pudendal artery and the pudendal nerve. Here they are described number 2 PDS, delayed absorbable suture. I use Prolene 0 number or 1 number. And the 2 stitches are taken in the double helical manner to the sacrospinous ligament, and the colpotomy is closed. A repair and P repair are done. And then this sutures are tied at the end, and the cervix comes to lie 4 to 6 centimeters cranial of the vulva towards the right sacrospinous ligament, but does not abut against the ligament. Lefort's colpoclysis, it was described for in 1876 by Leon Lefort for morbid patients who were not fit for surgery, wherein the anterior and posterior vaginal flaps were removed. And then the puborectal cervical fascia and the rectovaginal fascia were serially approximated. Dr. Sarogi sir has a very good video. I don't use this surgery, but I use the principles of surgery for wall prolapse. I'll just show a quick video for people to understand how Lefort's is done.
Steps of Lefort's by Dr. Samir.
So this is the, we mark the rectangular flaps anteriorly and then posteriorly. And then we remove these flaps. This is the place where the flaps have been removed. And these are the stay sutures at the, which are going to be the new apex. And then when serially one takes, I use 2-0 Vicryl and take serial box sutures. And once as you take the sutures, the prolapse gets reduced. Here I have shown the tube. So if your uterus is intact, one has to keep a tube because the cervix will keep on draining secretions and that they will come out to the tube. Here the last part is done. And after this surgery, one can always do a posterior repair by the standard steps. These are my references. There are very good manuals by Foxy. One in 2013 during the AICOG Mumbai, and one during the AICOG Lucknow 2020 in 2020, wherein all these vaginal surgeries are described, and few more things are there from this obstetric and gynec clinics of North America. I thank you very much for this opportunity and thank you for the patient hearing. Sorry if I have exceeded the time.
Thank you so much, Dr. Samir. Bhagyashri ma'am, Dr. Kamna, if you would like to say something.
Excellent talk, Dr. Samir sir. Thank you for enlightening us with various surgeries, means conservative surgeries, both abdominal and vaginal. So thank you very much, sir.
Thank you.
It was a wonderful presentation, Dr. Pradhan. Your experience was evident with the slides. We would have loved to see other videos also, but I think the time was a limitation for you. Because all these, as difficult was POPQ, as is your surgery difficult. There's lot,
I
it
have
needs
a
a lot of patience and
channel.
lot of practice.
I have a channel where I upload videos, but they are of vaginal surgeries. But then after this, a new MCI guidelines came. I stopped it from 1 year. But before that, during COVID times, there were 16 to 18 videos about advanced laparoscopy and vaginal surgeries, wherein this Laforts and all I have tried to show. I have shown sacrospinous fixation also, so that anybody wants to learn, they can learn with those videos. So it is with a voiceover.
Right, sir. And especially when we are teaching the residents, it comes back to the basic anatomy again. If you have a strong anatomy, then understanding of these surgeries becomes easy.
Anatomy is
yeah. It was a great presentation. We loved, and I love to see your videos also.
Thank you very much, ma'am.
Thank you. Thank you so much, Dr. Samir.
Thank you, madam.
Acha, another question, Dr. Samir. How is your experience with the proline? Does the patient ever comes back with that pricking sensation? Because we abandoned proline, using proline sometime back because of this complaint.
I use proline only for two cases. For all my vaginal hysterectomies, as a rule nowadays, after seeing Dr. Raja Maheshwari madam's high uterosacral ligament suspension and having an extensive discussion with Dr. Mahapatra sir, I have done almost 45 sacrospinous colpo fixations over last 20 years as a freelance vaginal surgeon. But then patient used to have some gluteal buttock pain. So I have shifted to high uterosacral ligament suspension, and I have shifted to basically prophylactic Accol's internal stitches. So I use proline only for Accol's 2 internal stitches. For high uterosacral ligament suspension, I use PDS. And for sacrospinous, I use proline, but I take it subepithelially. So it cannot be exposed in the vaginal cavity.
Yes. Thank you.
Thank you.
Ma'am, would you want me to introduce the chairperson?
Yeah.
Moving on to this third session, we have Dr. Arpit Vachhani ma'am with us. She's a consultant obstetrician and gynecologist, and also a menopause consultant at Atmiya Hospital, Surat, since 21 years. Madam is a menopause practitioner. She is also a member of the Menopause Society, and she has been the ex-assistant secretary of Surat OB-GYN Society. Ma'am, it's an honor to have you with us. We have Dr. Anjali Verma with us. She's the director and consultant of OB-GYN, Tirat Ram Hospital, Gurgaon. She has also been the vice president of Gurgaon OB-GYN Society, past secretary of Gurgaon OB-GYN Society, and her fields of interest are high-risk obstetrics. Welcome, ma'am. We have Dr. Neelam Sinha with us. She is being trained in laparoscopic surgery. She's a senior OB-GYN consultant at Muzaffarpur, working in Sinha Nursing Home, Juran Chapra. And ma'am has received the Foxy Achiever Award, which has been given by Rishikesh Pai and Dr. Madhuri Patil ma'am for her outstanding contribution. She has also received Foxy Appreciation Award for Nari Swasthya Jan Andolan Yatra. So welcome to today's session, ma'am. I request one of the chairpersons to please introduce the speaker, Dr. Kokila Bottakar ma'am.
Anjali ma'am, would you do the honors, please?
Sorry?
Dr. Anjali ma'am.
Yeah, ma'am, please introduce the speaker, ma'am. Dr. Anjali ma'am. Yeah.
So, welcome, Dr. Kokila. Welcome, Dr. Kakoli Boratkar. She's a postgraduate. Boratkar.
Yeah,
Yes,
ma'am. It is difficult pronouncing it.
So
yes,
she's
ma'am,
a post. Sorry. So she's a postgraduate from Tata Memorial Hospital, Mumbai. She's done her diploma in expert imaging in fetal medicine from University of Barcelona. She's a... Sorry.
Yeah, you're audible.
She's a gynec and pelvic imaging. IOTA Europe certified person. She's presented many papers and posters in various national and international conferences. She's a faculty in national and international conferences. She's a member of IRIA, ICRI, SFM, and she has been a BCFRG faculty as well as CCFRG faculty. Her main areas of interest are fetal medicine and interventions with gynec and pelvic floor imaging, breast imaging and interventions. Welcome, Dr. Akoli.
Thank you, everyone. And at the outset, I'd like to thank for giving me this opportunity. And it's very nice to be part of all of you. Am I audible? Am I
yes,
audible?
Yes, ma'am, you're audible. Yes, ma'am,
Yeah,
you're audible. You're
I'm
audible.
just sharing my screen. Yeah. Okay. One moment. Yeah. Can you see my screen?
Yes.
Yeah. Yeah.
Yes, ma'am,
Okay.
it's visible.
Yeah, okay. I'll be unlocking the pelvic floor, the meets, facts, and protocols for you, with special emphasis on the prolapse. Actually, it's been just 2 days. Asha ma'am told me that you have to tailor it to prolapse, but there'll be a few other things. My apologies for that, because I didn't get really time to tailor the talk as per the whatever, and I just added one prolapse a minute back. So I'll be taking you through the pelvic floor imaging per se from the obstetric gynecological perspective. Now, to start with, when we talk about the epidemiology, and though it's a very neglected segment, but if we come to see the prevalence, then 25% of women aged 25 or older has at least one symptomatic pelvic floor disease, and it is more frequent in the older age group, as we all know, and 1 in 8 women requiring a surgery. And the risk factors are mainly vaginal delivery, predominantly forceps delivery. It is more common in the elderly age group, more than 80 years, and with parity more than 20, any pregnancy which has gone beyond 20 weeks, a prior hysterectomy, or presence of comorbid conditions. This we all know. But what we don't know, and we are seeing more frequently, is that almost every 15 days, I get 3 females of the adolescent age group coming with one or the other symptom of pelvic floor, predominantly the urinary incontinence. And these are thought to be something or the other. And this is the segment which we should notice, and we should be caring for them. Then coming to the pelvic floor diseases, be it prolapse or in any form, it has a huge socioeconomic impact, because people are not very apprehensive to come to the clinician. They feel, there is a low self-esteem, there's a lot of loss of productivity, but still they don't come out to the doctor. But what it is more important is that these surgeries are not very successful in the first attempts, and there are a lot of failures also. So that is the reason why there is a lot of people don't come up, and the multiple visits are there to the doctor. And that is why the appropriate knowledge of how to diagnose these conditions and how to treat these conditions is very important, because, and also to consider that they have got a very high risk of recurrence. Now, in this country, we have seen that we are coming with more and more of the aging population. Okay, so in the next 40 years, when majority of our population ages, the burden of the pelvic floor disease will be more and more, and there will be a greater need for trained specialists in the field of pelvic medicine. Now, having introduced you to the epidemiology perspective, I'd like to take you what is the pelvic floor. Now, when we talk about the pelvic floor, we talk about the diamond-shaped structures. I'm taking you through because few of your obstetricians, you are doing the obstetric ultrasound, and also you come across many pelvic floor diseases. So I'll take you through how we look at it from the radiological perspective. Whatever we see here, I'm putting the inverted image for you, is because you need to get used to the inverted image seeing, because that is how a perineal ultrasound is done. Now, when we talk about the pelvic floor here, we talk about a diamond-shaped structure which is inferior to the pelvic diaphragm and anteriorly bounded by the symphysis pubis and posteriorly by the coccyx, as you can see here. Anteriorly, it is housed the urogenital triangle, which is seen here, the bladder and the urethra. And in the middle, we find the cervix and the vagina. And posteriorly, you find the anorectal canal. These are the 3 important structures. And when we talk about prolapse, we talk about these structures coming down And that is what is called as prolapse. Now, taking you through the techniques, if you want to start doing the ultrasound, it was initially started in 1980 by a transabdominal ultrasound, and then followed by transvaginal and transrectal. And today, when we talk about pelvic floor ultrasound, we all talk about the translabial or the transperineal, which was introduced in 1986. And by this, what I mean is that we usually mean a transvaginal transducer, condoms being put on it, which is put on the introitus as you put here. That's why it's called the introital ultrasound. You can also do it with a normal probe, which is the convex probe here, but you definitely need a volume transducer. A perineal or a pelvic floor ultrasound is never complete without a 3D ultrasound. So that's very, very important. And we need to take dynamic loops. It's important. And we need to know all the advanced techniques which are done, like an omni view, a sin loop, and dynamic maneuvers are very important for diagnosing, because it's not about just one pathology. We need to see the entire pelvis, all the organs, the associated pathologies needs to be mainly ruled out, besides the one which is very evident to us. The positioning of the patient is the dorsal lithotomy position, which is the hips flex and abducted. But most important, you should remember, whenever you are looking for a pelvic organ prolapse, you have to ask the patient to do a Valsalva's maneuver, and it has to be seen in the semi-reclining position. Quite a lot of times in the supine position, when we put a pillow below the butts, it doesn't show the prolapse. So the pillow is to be removed, and on top of it, the upper part of the body has to be elevated so that the organs really come down. The bladder has to be partially filled. It's not empty. And the bowel emptying is optional. In case you feel that the bowel is fully loaded, you can, otherwise you can do it without that. Now, when I talk about the common indications, we talk about urinary incontinence, we talk about recurrent infections, we talk about voiding dysfunction, pelvic organ prolapse, and also most important is that quite a lot of times pelvic organ prolapse present with low back pain, hip pain, pain during intercourse, tailbone pain, lower abdominal pain. These are very common indications of the pelvic floor diseases when we talk about. They're very non-specific symptoms, but then we come across with some of the other organ prolapse. And then finally, one of these organ prolapse, once it is treated, a very important aspect of imaging is to monitor whether they are working, functioning properly or not. That's another aspect of monitoring. And finally, the levator NI assessment. That's very important after childbirth and after any injury, or if there is any symptom of prolapse or any mass coming down, the levator has to be always evaluated. Now, coming to the mid-sagittal view, when we put the transducer, as I've already told you, what we get on the screen is an inverted image. On the inverted image, anteriorly we find the pubic symphysis, and posteriorly you find the levator process. Now, between that, the line of the levator floor is not absolutely parallel to the angle of installation. It's at an angle. This is the pelvic floor angle. Okay, this is the levator angle. Now, what we find anteriorly is the urethra. In the middle, we find the vagina, and posteriorly, we find the anorectum. Okay, these are the three structures you can see here. You can see the air in the vagina. You can see the endovaginal fascia. You can see the endorectal fascia. And then you can see the anorectal canal, which is usually seen at an angle. And then once we should remember that when you do the basic acquisition, this acquisition has to be in a wide angle of inclination. So during the grayscale, if you don't get these two structures, the pubic symphysis and the levator plate posteriorly, then on the 3D, you cannot evaluate. So that's very, very important. You have to take the maximum angle of inclination when you start your primary acquisition. And this acquisition has to be done at rest. It has to be done in contraction, and it has to be done in Valsalva's maneuver. The same image has to be taken in all the three positions. That's important. And then how we analyze these structures. You get the pubic symphysis here. You get anteriorly the bladder with the urethra down there. Then you find the vagina here. You can see the vagina in the air in the vaginal lumen. You can find the anorectum here. And the anorectum is as an angle, as I've already told you. And then the anorectum, you can also see the sphincters there. You can see the dark external sphincter sphincter, the bright external sphincters, the dark internal sphincters, and then anal mucosa is usually seen as white. And this is the anorectal angle, which is usually obtuse, and it changes as the patient produces a Valsalva's maneuver, and I'll take you through. Now, once you have done the 2D acquisition, the most important thing is to do a 3D acquisition. So when you do a 3D acquisition, what you should do is you have to go to the multiplanar imaging mode. You've taken the 2D image, you press the MPR in your machine, and once you press the MPR in your machine, you have to adjust the 3 planes. So for the sagittal, what you do is that you'd get the angle. Initially, the angle was not, the image was like this, and the angle of the plane, the levator plane, was at an angle. Now you twist the button and you get the levator plate approximately parallel to the horizon. So you get a parallel, you rotate the plane, and then on the coronal you just rotate the buttons so that you get both the pubic symphysis. As you see here, the pubic symphysis should be joined together. Once you play around with these 2 images, you're definitely going to get a good 3D image here. So this is the levator sling you can see here, and all the 3 structures housed together, and how nicely you can see the levator ani here very nicely. Now, once you have done that, once you've done this, you have to put the rendering box. So how do we get this image? Once we put the rendering box, you can put the box between the one point at the pubic symphysis and other at the levator plate. And once you keep opening the box till the time you get the good width of the levator here, and then you will get a good 3D image. And once you get the 3D image, what should you get? Should get the pubic symphysis and the rami anteriorly. You have to get the urethra after that. You have to get the butterfly-shaped vagina. I'll keep this image in mind, because when I show you uterine prolapse, you'll imagine it's not like this. It's different. So this is the uterine vagina here. You see the anorectal canal very nicely. This is the external sphincter, the internal sphincter, and the anal mucosa, which is called star-shaped. Okay. Now, it's very important that and this sling of muscle is a puborectalis sling, as you see here. Now, what you need to remember is that once you have done this image, you also have to press the TUI button in your machine if you have, so that you can get like a CT scan, you can get multiplanar imagings. Because when you have to report a particular tear as a tear, you cannot say if you see it on one plane, because what happens is when you have a tear, there are a lot of partial tears, there are a lot of weakness in the muscles. So if you want to say it's a tear, it has to be a through and through tear, and then it has to be seen in multiple sections. So to see that it is confirm that it is there in multiple sections, we need to get the TUI VCAD like this. So these are like CT scan sections. We can get it on ultrasound, and that is how we confirm, and I'll take you through. Now, when we how do you perform a Valsalva's maneuver? This is the first thing what you should do when you have a pelvic organ prolapse. Now, I'll take you through how we go through the Valsalva's maneuver. You see this lady is forcing. Okay, so when this lady is forcing, you can see on the right side, initially your canal, the levator canal was absolutely not patulous. Now you can see that the whole thing is patulous. Okay, it's patulous and the bladder is coming down, as you can see on the left side. Okay, so you ask the lady to apply force, and it has to be minimum 6 seconds. Okay, and the levator coactivation has to be avoided. Now, what is levator coactivation? Now, levator coactivation is basically whenever you ask a person, whenever these ladies have prolapse, they have a compensatory mechanism which they have developed on their own. That means when you hold flatus, or you want to desperately, you have an urge for passing urine or stool, you have a normal maneuver where you can hold it. Okay, so what these people do is that because they know their organs prolapse, they have a natural mechanism to compensate, against that. So that is called the levator reactivity. So you can see here, whenever there is a levator reactivation, this is a compensatory mechanism. Instead of going down, you see that there's a cranioventral shift of these structures. You can see that the bladder would move up. That is like squeezing of the pelvic floor. Okay, this levator reactivity has to be avoided. Okay, whenever you are looking at her, you can see this as and when she squeezes, this moves up. this moves up. The bladder moves up, the uterus moves, cervicovaginal canal moves up. So this is called a levator ani reactivity. And that reactivity is what? We need to assess the reactivity, but that has to be specifically assessed after the prolapse is assessed. Once you tell her you force down, you assess the prolapse, and then you assess the reactivity. Why the reactivity is important? Because there is little bit of prolapse or not much of it. She may not need a surgical intervention, whether it's a bladder or it's a uterovaginal prolapse, and we might treat her with physiotherapy. And also the success of surgeries depend on how much is a levator contractility. So you can see here on the right hand side, I've drawn a line from the pubic symphysis, and I've drawn a line from the bladder up to the base of the bladder at rest. And then on the right side, I have asked her to contract, and the bladder base has moved up. You can see that the distance is increased. So she has got a contractility by which she is able to push the bladder up into the abdomen. So that is called the levator ani reactivity, and that is to be assessed and always told to the surgeon before we decide on whether it's a urogenital urological surgery or obstetrics gynecological surgery. Now, another thing which you need to assess is the funneling. Because all these girls which come with us with prolapse, or they come with urogenital complaints, they usually have some amount of funneling. And how we assess that? We assess that there'll be some grayscale echoes there, which is a weak grayscale echoes called streaming. And on color, we'll see color Doppler here. Then this would be saying that this funneling could be ultrasound sign of urinary incontinence, which can be demonstrated. Now, once we have taken all these, we need definite objective measurements to say that yes, we are dealing with a prolapse, and how much is it. So when we deal with the prolapse, we take this line like this. We draw a first line like this, one along the pubic symphysis and one along the x-axis. Okay, this is a horizontal line drawn from the lower border of the pubic symphysis. Next, what we do is we draw a line from here, from the along the neck of the bladder. We draw a line along the neck of the bladder. This is the bladder neck to that horizontal plane. Okay, and this length, whatever we get, is the urethral height or the urethral length. Okay, and that should be approximately 20 millimeter at rest and 14 millimeter at Valsalva's. Then what we do is that we ask the patient to perform Valsalva's maneuver, and we see how much of this angle is moving anteriorly up, and we measure this angle. The normal angle at rest is what it forms. One line we draw from the bladder angle to this x-axis, and one along the line of the urethra. Whatever we are seeing is red is the normal urethral angle, which should be less than 40 degrees. Now, once the lady performs the Valsalvas, I'll take you through in the examples, and whenever she has an incontinence, what happens is that this bladder goes down and this urethral angle approximately becomes horizontal to this. Okay, so this angle becomes increased. So that is abnormal. And then we get another angle, which is the posterior retrovesical angle. Normally, the bladder base and the urethra should be at an angle. If that angle is lost, then what happens? There'll definitely be incontinence because it will be a straight line. So how would there be some, there'll be some angle gives some amount of resistance to incontinence. So generally, when there is a prolapse and there's an incontinence associated with that, then we do get an angle which is more, it's not an acute angle. It's usually 180 at Valsalvas, and these patients generally present with angle approximately 180, 160, something like that. Now, at the end of it, we come to prolapse. Now, how do we measure the prolapse? We measure the prolapse from the same horizontal line. Okay, this is the bladder neck distance. We bladder the bladder neck to the bladder neck, from the bladder neck to this line, then the bladder posterior wall of the bladder to the symphysis pubis distance, then the cervix to the symphysis pubis distance, and the rectal ampulla to the symphysis pubis distance. So in the same image which I had shown you, these structures to that horizontal line has to be measured. And if we talk about the bladder neck descent, it's approximately 15 to 40 mm, which is considered as bladder neck. And for the bladder base, we consider around 10 mm as the upper upper limit. And for the anterior and the cervix, we consider 10 mm below the pubic symphysis. If it goes down, it has to be within this line. If it goes below this line, 10 mm below this line, we call it as prolapse. And for this rectum, we consider a distance which is going down below this line. It should be approximately 15 mm. So the prolapse is classified as how much these organs goes below this line. So that is called as prolapse. Now, after we have measured and seen everything, we need to look at the levator hiatus. Okay. Now, for the levator hiatus, I've already told you that we have to do a 3D reconstruction wherein we see this levator. Now, what do we need to do here? We need to measure the area of the levator. Okay. And once we get the area, we can draw lines in the machine wherein we can get there's a button, there is a genetic, it says that you can measure the area. So you measure the area, then you draw a line through the urethra there, and you see the distance from one side to the other. Now, this area tells us how patulous is the levator hiatus. Okay, so it should be approximately 6 to 18 square centimeters at rest, and it goes to around 14 to 20 in the Valsalva's maneuver. And then this line from the middle of the urethra to the maximum width of the levator is called the urethral levator gap. If it is asymmetrical, we can definitely suspect that there could be some amount of a tear on one side. That is why it's asymmetrical. So these lines basically tell us whether there's an asymmetry, and we should look at the tear at that particular point. So this is why this line is important. And this stars, whatever I have put in, is the paraurethral sulcus or the sulcus vaginalis. So this is the place where generally the slings are put. So if the slings are malfunctioning or the patient is having some complaints going inside the urethra, impinging on the adjacent structures, then we have to see this particular area, and that is why this paraurethral sulci is very, very important. Now, when we come to the interior compartment, what are we looking at? We are looking at stress incontinence, urge incontinence, avoiding dysfunctions. And then when we look at stress incontinence, if the patient comes with stress incontinence, it's usually a mobile or a fixed hypermobile urethra. You can get reduced or absent pelvic floor reactivity. You can get a cystocele, funneling of the urethra, or reflux. These are the things you find in the patient in stress incontinence. And if a lady comes with urge incontinence, we don't find this. What we find is usually a thickened bladder. We find either urethral or vesical masses. So you might find some other disorders there. You might find a diverticular uterine fibroids and funneling. So we're not expecting a cystocele when the lady presents with urge incontinence. So based on the symptoms, we can judge what could be the problem we are expecting. Now, when you're putting, a lot of you are putting a lot of using these TVT tapes and TOT tapes. So whenever we put these tapes, we have to, before putting these tapes, if we're doing, we need to measure the urethral length, okay? Because these tapes are put in the mid urethra. So that is why the distance from the tape urethral distance is, you have to measure the distance from the external opening to the bladder neck, tells you how much is the length of the urethra, so that you can put the tapes exactly in the middle, and then the incision can be put properly because it can exactly fall into place if the distance is measured correctly. Okay, and most likely we should remember that in cases of an associated uterine prolapse, the prolapse surgery needs to precede the incontinence surgery, because and then that is why the colpus suspension is done with the vagina. So that is why whenever you're dealing with a vaginal prolapse, we need to look at the cystocele together, because the symptoms would not be cured unless and until we deal with both the organs. So whenever we are clinically suspecting a uterovaginal prolapse, we also need to look at the bladder prolapse. We also need to look at the urethra and see what are the and also gives the dimensions from the clinical perspective as to what is the length of the urethra and the angle of the urethra, so that and I'll take you to the clinical perspectives. Okay, now when we take in, this is an example where you can see that this is the bladder here, you can see down, and the urethra is at an angle. So you can see a large cystocele there. This is a cystocele, but the urethra is forming an acute angle with the bladder. So what does it mean? It means that there is a the bladder has come down. It is more than 10 millimeters below the pubic symphysis line. This is a pubic symphysis line here, and the bladder has gone significantly down there. On the right side, you can see on the valsalva, the bladder is opening in the levator hiatus. So it has come down. So the bladder is prolapsed. But what is important is that this lady is not going to present with incontinence, because in spite of the prolapse, she is having a proper angle, acute angle between the urethra and the bladder. Another example, as you see here, is there. You can see in this case there's a prolapse. You can see there's no angle. The urethra is approximately a 0 angle. It's at 180 degree with the base of the bladder. It's 192 degrees. And this is again 141 degrees. So what happens when you have a straightened line between the urethra and the bladder? This lady, in spite of having a prolapse, is definitely going to have a prolapse of the bladder as well as an associated incontinence. That is important. And then you have to look at the levator tear, because if you have a levator defect and this levator is teared and there is an incontinence, there's a bladder incontinence, the bladder prolapse, then the patient does not present usually with incontinence. The cause of prolapse is usually because of voiding dysfunction, because a huge bladder has come down. So that is why it is usually urinary incontinence, retention, and that is usually due to urethral kinking. So that is important, that whenever you have a bladder which comes down and it's a huge bladder, you may not necessarily have an incontinence. It could be because of the physical coming down of the bladder, which is causing the problem for the incontinence. So it has to be separately evaluated whether, then in this case, the voiding problems, whatever she is having, would be cured by the curing of the levator. So without the levator, if she goes for an incontinence surgery, then the surgery is not going to be a success. The levator repairs has to be done prior to the urethral surgeries. Now, once we come to the middle compartment, whenever you have a prolapse, whenever it's a procedentia grade 3, you don't need an ultrasound for a diagnosis. It's usually a clinical diagnosis. So when do you need us? You need us whenever you have something like this. In this case, you can see that this is an anterior rectal prolapse. It's an anterior wall rectal prolapse. Okay, so this is when, which was felt as something coming out from the introitus, and that was not a uterovaginal prolapse. So this is when you need us. And this is another case. You can see that this is an enterocele. You can see this video. This is an enterocele which was coming down. And then if you have a this is a case of uterovaginal descent here. Okay. So for all these, posterior prolapse could be an enterocele. It could be an intersusception. So anything which comes down, whenever you have grade 1, that is the time when the patient presents with vague complaints. That is the time an ultrasound is of use. To see whether it's a prolapse related disorder, and 2, to differentiate whether it is a bladder or it's a uterovaginal or uterocervical descent, or it is something else which is bulging out. So that is the time ultrasound comes to the use, and not when we have a grade 3 prolapse. Now the measurement of the prolapse, this is a uterocervical prolapse. This is you can see here that when this lady is forcing, as you see here, this lady is forcing, you can see here that this is a pubic symphysis, and here is the cervicovaginal junction. This is a pubic symphysis here, and this is a cervicovaginal junction. I'll repeat the video. She's applying valsalvas. The bladder is here. The bladder is not prolapsed. Only the uterocervix is prolapsed down there. Okay, so this is the prolapse, and this was not a symptomatic lady. And this is on the right hand side. You can see that the same lady also has you can see, I've shown you the butterfly shaped vagina in this, and this is much bigger. So this is a cervix along with the vagina, which has come down to the levator hiatus. So this is another way you can confirm that it has come to the hiatus. You draw a line along the hiatus, take a 3D reconstruction. You can nicely see that the cervix has descent down there. So that is how you diagnose a uterocervical prolapse. This is again in the same case. Then you find here, this is a very nice, interesting case. You can find here that there's a balloon hiatus, which is approximately 25 centimeter. You can find a big balloon hiatus. Then that is very important, that when, even if the lady is not presenting with a uterocervical prolapse, even when there is a cystocele or a urinary complaint, the hiatus repair has to be done. That is why this hiatus, the bladder has prolapsed, but in this case, if you do a incontinence surgery without a hiatus repair, it's not going to be a success. So that is why the levator hiatus assessment is very important. And here on this case, you can see a levator tear, which is seen in the 5 o'clock position, a nice levator tear. This is again very interesting case. This lady came to me with vague pain. She had nothing. She was a postmenopausal lady. She came with vague pain and she couldn't even sit. And this is when I did an ultrasound and I saw that she has levator ani deficiency. You can see here there's hardly anything in the levator. So she had extreme pain. Okay. So this was I thought there was prolapse. There was no prolapse. I thought this could be a marker to predict prolapse, and she had chronic pelvic pain. She was put on local estrogen therapy and she was put on physiotherapy. And this was on 22nd June 2022. And she comes back to me on 14 September 2022. And you see how nicely the ring has developed nicely. So this is how physiotherapy and estrogen therapy helps. And this levator ani insufficiency is to be a recognized entity where you can, postmenopausal ladies may present with chronic pelvic pain, and we don't find anything in those people. Then these are the levator pathologies. So whenever you have a levator tear, most important is that you have to take this multiplanar imaging at 2.5 slice intervals, and the central slide should show the tear, and it should be seen in 3 slices. So you can see here, I can see the tear in the 3rd slice, the 4th slice, and the 5th slide. Okay. So once I see in 3 slices, I can say that this is definitely a contraction, because these ladies are generally postmenopausal ladies, and this levator is not as thick as the young people. So that is why one important thing is that you have to take this levator ani asking the lady to squeeze. So once the squeezes, the levator tears are very well demonstrated, and even then you have to see in 3 consecutive slices, and only then you can call it as a levator tear, the entire ring, and it is described in the clockwise manner. Now, when we look at the levator tear, you can see here, this is again a case of levator tear. You can see here, there is a tear here, there is a tear here, there is a tear here. So these are the cases where you can here, but this is a weakness of the levator muscle. This is an old lady. So this was a prolapse there, and you can see the levator this way. So this is how levator tears are seen. The echogenic ring of the levator ani, you can see deficiencies there, which are seen in black, and that is called as levator tear. So I have taken you through how you take the area of the levator and the prolapse and how you see the tears. Now, this is again another example where you can see that this is a prolapse here, which is associated with the rectocele here back. Okay, so this is a case where we have a rectocele associated with the cervical prolapse, cervicovaginal prolapse. Okay, this is another case where you have find the rectocele which is associated with the cervicovaginal prolapse. Okay. Now, there are certain other pathologies also should be noticed, which might come across in the may present across something coming out. So I'm taking you through a few examples. This is a urethral leiomyoma. So a urethral leiomyoma was thought to be a bulge coming out. So we needed to see, we saw the urethra, it was the vagina is behind, and this was an urethral leiomyoma. Urethral diverticulums are also sometimes could be a big urethral diverticulum can also present like something bulging out, and then finally a Gardner's duct 6 or can become infected, and that also may present with something coming out and can be confused to be a prolapse. Now, periurethral abscesses, this is again, these are a few examples where you, this was again thought to be, it was a periurethral abscess, which was thought to be a prolapse and maybe coming out. So this was a mass at the vestibule here. So we put a catheter there and we figured out that no, this is a periurethral abscess. Now, when we look at the post-operative assessment of the slings, okay, what you should look at is that once you put the sling and the patient comes with some complaints, or we do a routine post-operative evaluation, what you should look is that it should not be too proximal to the bladder neck. It should not be too outside. It should be in the middle third. That is along the vertical orientation. And along the horizontal orientation, it should not be too near, or it should not be too far. And it shouldn't be kinking and going inside into the urethral lumen. And that is what we need to monitor when we monitor these slings. In this case, you can see here that there's an indentation. This lady was put at a sling, surgery was performed. She came back and the sling comes inside, and it was hitting her. And she said that, no, I find that I'm uncomfortable. And when we do the 3D here, we could see that the sling is absolutely coming inside. And here, this is another example where you can see that the sling is coming inside and it is obstructing the urethral lumen. And this is a dislodged mesh with a recurrence of the cystocele. This is an obturator mesh dislodgement. So these are the problems which we can have when we deal with the surgery, and these are the surgical complications which we need to be aware of. Now, to the posterior compartment. The posterior compartment, the common indications what we need to see is fecal incontinence, flatus incontinence, prolapse, and the anorectal pathologies. Anorectal pathologies are mostly of the surgical concern, but the first former three could be of concern to the obstetric practitioners. Now, when we see the rectum, what we see is that very commonly the Bartholin cyst can be a confusion with the anorectal fistula. So that is why an anorectal abscess, determining where the anorectum is and whether it's an anorectal abscess which is coming to the posterior vagina or introitus, or it is the Bartholin cyst. That is something which is very important, because quite a lot of times a huge abscess could be a confusing thing. So knowing the anorectal pathology is very important when you have these things. So this is an anorectal angle. You can see here a normal anorectal angle is 100 degrees at rest, and whenever it is straight, you apply Valsalva's maneuver, it is straightened down. So if you have a lady with incontinence, this angle will not be there. It is usually deficient. And this is another place where this is another anal sphincter defect, and you can see a perianal abscess there. And this lady was again showing that this was a chronic perianal abscess. It was thought to be a vaginal pathology. It was thought to be a Bartholin's, but it was in fact anal abscess. So that is why these anal pathologies are also important to be evaluated when we evaluate for any pelvic floor disorder. Now, coming finally to ultrasound or MRI. Ultrasound is definitely a very good alternative to MRI, but MRI performs well when we are looking at levator pathologies. Levator pathologies on ultrasound sometimes can be a problem. So that is why, besides the levator pathologies, confirming for the anterior compartment, today we don't need MRI. We can definitely do very well with ultrasound itself. But definitely ultrasound has got a huge learning curve, and you need an expertise. So if you have the expertise, the good machine, and the learning curve has been met with, then in that case, ultrasound is almost equivalent to MRI, and only in very specific scenarios where we need to look at the levator and we might need the MRI, but that also in not all scenarios. Finally, I hope I am able to take you through whatever you had expected, and I hope that once we are all armed with the requisite detailing of the pelvic floor imaging and the prolapse organs, and we can definitely give all these elderly ladies a very healthy life in the years to come. Thank you all for a very patient hearing.
Thank you, Dr. Kakoli. Dr. Samir has put on his video. I think he has watched your program completely. Dr. Samir, first of all, comments from you, and then I would request the chairpersons to say something.
I'm so sorry, because this was actually, I didn't get time to tailor my talks of the pelvic floor.
Kakoli, excellent talk. In fact, I took notes from your talk and some photos and videos. Because I was always wondering, I attended one more talk by one more senior sonologist from Powai on this, but that time I could not understand a lot of it. And but now here I understood. I have only one question. I do surgeries for genuine stress incontinence, and I used to try and counsel my patients for urodynamic studies initially. That is why I don't have a very large number, because some of the patients used to get lost to follow up. My concern was that I had discussed this with a lot of people who have done urogynec specialization from abroad. Like one of them is done from Australia and one of them done from Cleveland Clinic. So first thing is we should not do any harm. So I should not put a sling for a detrusor dyssynergia or for a intrinsic sphincter. If it's a intrinsic sphincter deficiency,
That is the reason I said that if you're looking at
retropubic sling instead of TOT. So can I replace this ultrasound, the urodynamic studies with the ultrasound? Whether it will give me the Valsalva endpoint leak pressure or the urethral closure pressure and help me decide and counsel the patient about the same.
Pressures you cannot, but what we do is we on all these patients which we follow up, I get it on a routine basis. So we can actually see, I had shown you this case when you can actually see how the sling goes, how it goes inside, where it causes the obstruction, and that particular area which I showed you behind the urethra on the 3D image, that is the area which is the crux of it. And the sling, you can very nicely see the sling going inside, going obstruction. And
no, my question is not post-surgery. My question is pre-operatively. I want to decide whether I want to do a trans-obturator tape for a genuine stress incontinence. But if it is the patient is having an element of intrinsic sphincter deficiency,
you can. I didn't show those slides because see, if you have something called the ureterorhabdosphincter. That's a urethral rhabdosphincter, and that rhabdosphincter. I didn't show that because it.
Ma'am, we'll go through stress urinary incontinence in the future. We'll call you again. And
for that you can measure the thickness of the urethral rhabdosphincter and you can take it on 3D, and you can definitely say that this has a definite sphincter continence, whether the sphincter is good or not. You have the 3D dimensions as well as the 2D dimensions for that.
Dr. Anjali ma'am, would you like to say something? Dr. Rajni, Dr. Anjali.
Dr. Kokila has given an absolutely different parameter to urogyne. It was just wonderful, so crisp and so good, and in fact we would like to listen to her again and again, so it has to amalgamate more and more. Thank you so much, Dr. Kakali, and also I would like to thank you, Dr. Asha. It was a wonderful experience, wonderful academic bonanza out of the blue. It was very, very good. Thank you so much for making me a part of it.
Thank you.
Thank you so much, Dr.
Anjali, you have been here from the beginning, and Dr. Rajni, you also. Do you think this amalgamation was good? Starting with
my God, it was so excellent. I was spellbound, and it was so excellent. I was feeling like I have joined some international conference like that of urogynetics, and it was so excellent.
Show your face. We'll take a photo, please, Rajni, before I give the official vote of thanks.
Okay.
There should be at least one good photo, right? We've been studying so long. Arey, seedhe baitho, chalo mat. There. Thank you. So, thank you so much. I have no words. Starting from Hara sir to Dr. Samir and Dr. Kakoli, you are just a find for me. And all my chairpersons, guests of honor, Dr. Charmila, Dr. Abha, Dr. Vidya Thobbi, my chairpersons who pulled in at the last moment, Dr. Shalini is the secretary of Raipur Menopause Society. Dr. Rajni is an executive member. So I just pulled them in at the last moment, get in. And they obliged me, they are here. So thank you so much. Thank you so much for staying till the end. Dr. Kakoli, I hope you also enjoyed the interaction.
No, definitely. Only thing I was a little skeptical, I didn't have much time. So I was like, I couldn't tailor my talk. I just gave it.
But that's okay. See, the basic thing is that it should be a complete package. Like my father used to say that the eye is attached to the patient. It's not a separate organ by itself. So it's not just the uterus. People think only uterus and they don't think of anything surrounding it. So Dr. Samir also, the way he brought up all the types of surgery, Hara sir explaining the basics of how you're going to classify, what are the components, and you demonstrating that. It has been great. So, I thank you all, and I hope we will continue with some more topic of interest that, I'll give you more time next time. Thank you. Thank you.
Even I wanted to say, Dr. Kakuli, you are just awesome. And how nicely you demonstrated. We can just see the facial planes and everything, no? So if I was near you, I would have hugged you and I would really congratulated you. And it is a very wonderful session on USD and 3D acquisition, pre-op, post-op, in every, every aspect you told us so nicely. Very wonderful presentation. Thank you, madam. And nice to listen to you, Dr. Samir.
Bansal as well, who actually made me meet Dr. Kakoli. We were there at the same conference we've been, but Dr. Vandana Bansal was instrumental in introducing her. When I told her I'm looking for somebody to talk on the perineum and pelvis, she said, yeah, she'll do it.
You must start teaching sonologists how to
Well,
scan
that's a
for
request
prolapse.
which I'm getting from the Obstetric Gynecological Society, and I'm seriously thinking of taking.
You must
Yes,
start,
yes.
madam.
We will all
must
come
start.
to learn from you.
Yeah, it's a wonderful,
are
wonderful thing to elaborate, and लोगों के mind में आता ही नहीं है. They will just write collapse of the uterus. They will not write any levator plate and everything. They don't have even concept, I guess.